It's working with colleagues, maxillofacial surgeons, psychiatrists in facial pain. And sleep apnea is a very similar thing in that you'll be working with other, it may be respiratory physicians, there may be anesthetists who run the sleep clinics, and there may be psychiatrists involved as well. And it's important, if you've got this transitional areas, that you have enough information about that area to be certain that you can deal with the problems in a more wholesome manner and not just be looking at your end of the spectrum. So what I'm going to be able to achieve really is an overview. We're not going to be able to get a lot of detailed overview about obstructive sleep apnea, make you more aware of other sleep disorders which you should be thinking about and picking up or maybe assessed on in your exams, an overview of the assessment process and what treatment options are available to us. So the one thing to realize is that the sleep disorders is a very big spectrum of conditions. It involves physiological aspects, obstructive, which is what we deal with, neuropsychiatric, cognitive factors, and there's a whole list of things that can be associated with sleep disorders. And if you're going to deal with it, it is paramount that you're somewhat aware of these things. So I call these wake-up slides, and the reason they wake up are the other ones you can go to sleep on if you want to. These are the take-home messages, okay? So when your patient comes to you with snoring and hypersomnolence or daytime tiredness, I would suggest to you, you've got to look at all these things in a systematic manner. These are the commonest causes, not narcolepsy, obviously. These are the common causes you should look at first. You've got to look at sleep hygiene. Are they shift workers? Is there an element of insomnia and depression? And then you look at some of the medical conditions, which are limb movement disorders, together with narcolepsy, and even medical conditions such as diabetes, acromegaly, and hypothyroidism, before you start thinking about snoring and sleep apnea. So must have those in the back of your head every time that you're thinking about it. Narcolepsy is definitely an area that you'll be questioned on or know about, and the way to remember, it's a tetrad. It's 4 different symptom profiles put together. Daytime somnolence, which we've talked about already. Cataplexy. Cataplexy is sudden loss of muscle tone. And the dramatic ones are people who kind of drop down on the floor. That doesn't happen in real life. Most of the people will actually have either just lose the control of their head or their arm drops down. And these usually happens in times of emotional excitement. So somebody cracks a joke and suddenly this person's head tends to drop down. Sleep paralysis, it's usually quite subtle. So people may do is they develop strategies such that when someone's going to, automatically their hand goes up to the face when they're laughing because they overcome those elements. Sleep paralysis. This is when you wake up in the night and you're paralyzed. You can't move your limbs. How many people in the audience have had that? Very common, okay? So what happens is narcolepsy is where the realm of sleep and REM sleep and wakefulness loses its boundaries. So what you've got here is where some of the REM sleep behaviors of bodily paralysis come into wakefulness. And similarly, sleep comes into wakefulness. So these people who have narcolepsy, if they need to go to sleep, it doesn't matter. They could be doing the most exciting thing in the world, but they have to go to sleep. And they'll go to sleep 20 minutes, wake up refreshed as anything. So these people often have to sleep consistently through the day, irrespective of what they're doing. Unlike sleep apnea, who, if he's doing something very important and exciting, will manage to keep themselves awake. And it's only when they're waiting for you in the waiting room that you'll find them nodding off, or they're taking a break, or waiting at a junction in a car, they'll nod off. Sleep paralysis. They often may not admit this. It's worth asking them. Hypnagogic hallucinations are a little bit more complex. It's once again this concept of sleep, REM sleep. What happens to us in REM sleep? We dream. And what happens in wakefulness? We don't dream. We have reality in front of us. So this is the concept of dreams occurring, a perception of dreams occurring during what may be wakeful states. So narcolepsy is all about loss of those boundaries between REM sleep and wakefulness, which is where the symptoms come from. So remember those 4 categories in narcolepsy. Movement disorders often get a little bit confusing between periodic limb movement and restless leg syndrome. The restless leg syndromes have those 4 components again. There's always a sensory component. It's a feeling of itching or scratching or something. There is a motor restlessness. There's a need to move. And there's usually worse at night and it worse at rest. The key thing, their symptoms during being awake, the periodic lip movement is when you're asleep. Okay? The difference being your partner, or usually here, it's the partner who brings with snoring, it's always the partner pushing the other partner forward anyway. But here the partner says, he keeps kicking me at the night, or he's hitting me at the night. And what's happening is they're having random, very periodic leg movements, which often doesn't always disrupt the sleep pattern of the person, but that is periodic limb movement disorder. So if you're thinking about which is which, remember, that is when they're asleep, that is when they're awake, that has the 4 components related to it, and they're associated with iron deficiency anemia. So a large proportion of these people will also have 80% of them may have periodic limb movement disorder as well, and peripheral neuropathy. So 2 things to think about. So let's look at sleep apnea syndrome. So obstructive sleep apnea or obstructive sleep apnea syndrome is a spectrum of a condition. It's the same condition, just with worsening of airway obstruction, but reduction in incidence of these events. What happens to humans when we go from being awake to lying down or asleep? So if you have somebody who has sleep apnea, you lie them down, they don't snore. Something happens to them or obstruct. They're not obstructing through the day, so it's not a structural compromise that we can just correct and sort out. There is something that happens between being awake and being asleep. And that something is the loss of the muscle tone in the airway. We as humans have used our larynx more as a communication. And the compromise we've made is that we have no circumferential protection from the back of the nose to our laryngeal anatomy. It's reliant on muscle tone to keep our airway open. What happens between being awake and asleep is you lose that muscle tone. And what happens is that people who have, so these 3 categories, and this is the critical closure pressure of these individuals. If you have sleep disorder breathing 2, which is obstructive sleep apnea, your critical pressure is positive airway pressure. So at normal airway sea pressure, your airway collapses when you go to sleep. Normal individuals, you need about an average -5 or even sometimes -10 millimeters of mercury to collapse. So you're sucking to create a collapse of the airway. And snorers are transitionally in between. So what is happening is these people's airway is collapsing at airway pressures. What does that cause? It causes quite a significant degree of morbidity. You obviously have the neurocognitive problems of depression, daytime drowsiness, and insomnia, but you also have a memory loss, but you also have quite a significant degree of medical problems of hypertension, early death. You have 3.8 odds ratio of death if you have sleep apnea than somebody who doesn't have sleep apnea. If you cured all cancers, how much lifespan would you increase? Do you know? This is a magical, well-known figure. 7 years. Actually, if you cured all cancers, you will only increase human life by 7 years. If you cured sleep apnea, how many years you will increase life by? 14 years. Okay? So although we're obsessed with cancer, it's not cancer that's going to kill you. It's chronic disease that is going to kill you. It's chronic Cardiac disease, diabetes, heart failure, hypertension, strokes. That's what's going to kill you. A little bit of logistics, important to know. We normally categorize them into 3 categories: mild, moderate, severe. Mild, in other words, up to 5 times per hour, stopping breathing for more than 10 seconds and desaturating by 4% is normal. Is it normal in children? No. So children's sleep apnea and adult sleep apnea are very different entities. The adult sleep apnea is a classical obese person, lethargic, doesn't do one. The children's sleep apnea is the hyperactive young boy who has poor attention span and is failure to thrive. They're 2 completely different entities. But we categorize them in those. Why? I have no idea. Traditionally, that's what we do. So when do you investigate? You need to investigate anybody who presents with snoring and has witness apneas or any daytime somnolence, nocturnal choking or restlessness at night, morning headaches, and I would also put anuresis. And the one question often worth asking is, how often do you wake up at night? Well, so I wake up twice. I just go to the toilet. A 40-year-old man sitting in front of you saying that he needs to go to the toilet twice to pass water is not normal. If an 80-year-old, 70-year-old said that to you, you would understand, prostate, etc. But a 40-year-old, it's not normal. Anuresis is another way of presentation of sleep apnea. Any high-risk factors, obviously obesity, if the partner has a history of witness apneic events, acromegaly, hypothyroidism, much higher incidence of sleep apnea, and then have a very low threshold for investigating. People who have labile hypertension, nocturnal angina, arrhythmias, you would think of them in these categories as well. So when you're doing your assessment, what you're doing, you have 3 levels of assessment. You have a simple screening sleep study, a more limited or a more detailed sleep study, and then you need to evaluate the airway. Pulse oximetry is a good, nice, economic way of assessing the sleep apnea, and I think a lot of the clinics would do that, but it's only a screening tool. You cannot really take its results definitively, because it does, although it may have a higher sensitivity rate, it's very poorly specific, so you may be picking up the wrong category of people and putting them on CPAP. So it's good as a screening tool, but you've got to take it in with the history, etc. But the polysomnography is obviously the gold standard, and that unfortunately may not be available to everybody, because we can then correlate different types of sleep disorders at the same time. So when we're looking at the airway, assessment of the airway, we can do that in many ways. Or it has been done in many ways. Most of them are not effective and not used in clinical practice. But just to be aware, acoustic reflections, you can look at fluoroscopy, cephalometry, CT, dynamic MRI, so you're making people sleep in MRI scans. It's good for clinical trials, but probably not a very practical solution, way of diagnosis. And then we look at 2 things that we normally use is apneograph and sedation endoscopy. Anybody used the apneograph in the audience or come across it before? One person, okay. So apneograph really is a way of assessing the upper airway pressure changes during sleep. And they measures these different indices. So these are the things we would be doing: clinical examination, awake endoscopy. Be cautious about using awake endoscopy as a tool to localize where the obstruction is occurring. Yes, it's an indicator, but the key thing is when you're awake, you've got muscle tone. That does not equate to what your airway behaves like when you go to sleep. So the 2 are very different. We use a surrogate called sedation nasoendoscopy, whereby we give a sedative to create the loss of muscle tone and then see how the dynamics of the airway work. But the apneograph measures these indices. It's got pressure sensors. You put it in the clinic, the patient goes home with that, and then they come back and we can get a full assessment of the airway changes happening, which area is collapsing and which isn't. The other way we assess it is with sedation nasoendoscopy, and this is an example of somebody with what would be considered a palatal flutter. They're supine in the anesthetic room with propofol anesthesia, titrate it so that they're actually not asleep. And ideally, you want to do use monitoring at the same time. And you're looking at what's happening to the dynamics of the airway as they breathe in. And obviously, it's a multi-segmental problem. So you want to really be assessing the lower airway as well. And you also want to be seeing what's happening at the lower airway, but also what happens when you protrude the jaw. So a jaw thrust, which simulates a mandibular advancement device, will tell you how so this is a jaw thrust there. You can see how the airway suddenly changed. The palatal flutter is still continuing, but the lower airway has suddenly improved quite significantly by simply just pulling the lower jaw forward. During this procedure, it gives you an indication of what's happening. So treatment options. So what we have is on the severe end, we really have three treatment options. When you've got severe sleep apnea, your gold standard is CPAP. Your other options are surgical options, which we'll talk about in a bit. And now there are also implanted pacemakers. So what you have is a pacemaker for the hypoglossal nerve, and it picks up a respiratory arrest by the virtue of the change in the thoracic pressures and diaphragmatic movement, and then it gives a small, low-level stimulation to the hypoglossal nerve. The tongue contracts, pulls forward, and the airway obstruction is overcome. In between, you really have things like mandibular advancement device, which are effective for mild to moderate sleep apnea, and also nasal surgery can be assistant in this area. And then you've got a whole gamut of things that patients will pick up over the counter. Most of them are useless, got no value at all. They're just driving a whole commercial industry of things like watches and nasal prongs and chin straps, etc. So nasal surgery definitely has a role. When it comes to moderate to severe sleep apnea, has a very limited role in that it improves the compliance with CPAP and optimizes your ability to convert somebody who's having an oral mask to a nasal mask, which has a higher compliance rate. The key thing is that there are certain physiological reflexes. So if you sleep with your mouth closed, you're less likely to obstruct your airway because there's a nasopharyngeal reflex that occurs at night when you're asleep. So airflow through the nose causes an increased tone in the pharyngeal muscle. You lose that the minute you open your mouth, and the airflow now goes through your mouth. But the other thing that happens is the fixation point for the attachment of the tongue, which is fixed to the teeth, drops. The tongue drops backwards. Your airway gets more compromised by opening your mouth. So overall, nasal surgery is definitely useful. It's rarely curative, but it's very good as an adjuvant treatment for sleep apnea. When you're looking at surgical treatments, you're really looking effective surgical treatments. You're looking at mandibular maxillary advancements. So you have to move the upper and lower jaw forward enough to widen the airway such that when they sleep, although the airway collapses and reduces in muscle tone, it doesn't obstruct entirely. Yes, you can anticipate quite significant degree of surgery. This is just a summary of the different types of procedures: radiofrequency, laser-assisted, radiofrequency tongue-based, coblation, upper UVPP, suspension, multi-segmental surgery, M&A, and where this data suggests its efficacy lies. You need to be aware of them, but I don't think you need to be going through all of them today. So interesting areas where things are developing is using laser surgery for tongue base reduction. TORS, that's quite an effective way of reducing tongue base collapse. Obviously, we talked about the implantable devices. There are other devices where you're using electrical current through the day to try and tone up the tongue muscle and the pharyngeal tone so that it doesn't collapse so much at night. And the key thing I'd like you to be aware of the wider spectrum of what you're dealing with. Do not look at it like you're blindfolded and feeding an elephant. So somebody thinks it's a trunk, somebody thinks it's a tail, somebody thinks it's flat like the ears. You've got to get the overall picture in your head if you're in that environment. Understand the pathophysiology of sleep disorder breathing, and don't just think surgery is really is a physical opening. It's not actually dealing with the core causation of your problem. Adequate assessment and appropriate surgical interventions would be my suggestions. Thank you very much.